Okay, Bismillah ar-Rahman ar-Rahim. So we will start our Saudi Retina Society session, chaired by our Dr. Hassan Adibi, and I think he's going to start. So Dr. Hassan is a senior academic consultant and professor of vitreoretinal surgery and chief of uveitis at King Khalid Hospital. And he will talk to us today about the role of scleral buckle with small gauge vitrectomy. So please.
Thank you, Dr. Saad, for really your introductions. First of all, I would like to thank Dr. Muhammad Al-Amri as the head of scientific committee for invitation of Saudi Retina Group to participate in MAYOMS 2022. And it's a pleasure to start the sessions with my talk, role of scleral buckle with the small gauge vitrectomy. Always we have debatable questions, always, and is the addition of scleral buckle to BBF in the treatment of primary rheumatogenic retinal detachment increase single surgery anatomic success rate or single operation anatomic success rate of affects proliferative diabetic retinopathy incident. So this is really a big question, and usually we have debate about that in most of our. So we're looking for the small gauge vitrectomy. It becomes increasingly standard procedures for the treatment of primary rheumatogenic retinal detachment that characterized by shortened operative times, lowered rates of post-operative inflammations, wide-angle viewing systems that enhance the surgeon confidence, as well hastened better visual recovery. Looking for Medicare data, if you look for the years 1997, the scleral buckle was 38, and in 2007 decreased to 9%, while BBF 45% in 1997, and in 2007 increased to 73%. In Taiwan, BBF in 1997 was 47, and in 2005 increased to 61. So no consensus has been reached within the vitreoretinal community as the severity of either performing BBF alone or combined. However, previous evidence may support the use of combined SB with BBF over BBF alone. And the purpose of these presentations actually to review and highlight the role and surgical outcome of scleral buckling plus small gauge vitrectomy for primary repair of rheumatogenic retinal detachment. This is the data that we have it. The small gauge, improved success rate for the treatment of primary rheumatogenic retinal detachment, and that's contributing to the function of vitrectomy, which improves peripheral visibility and reduces the occurrence of the proliferative vitreoretinopathy. Some studies showed that in pseudophakic eyes, the anatomic success rate between BBF and combined procedure techniques appears to be similar, while others showed that SB with BBF versus BBF alone were similarly efficacious for repair of primary retinal detachment of varying complexity. If you're looking for single surgery anatomic success, BFR incidence and the final visual acuity were not significantly different in both procedures. BBF and BBF with scleral buckle for primary repairs of pediatric retinal detachment have comparable, as we see the study by Dr. At-Taysan, results in regard to anatomical success and rate of post-operative complication, where showed that no difference. But actually we have to take an attention, especially in pediatric complex type of retinal detachment. When we are looking for combined BBF and scleral buckle surgery that may associated with decreased risk for retinal detachment when compared to BBF for repair of phakic RD. So there is difference between phakic patient having retinal detachment and the patient who's having pseudophakic retinal detachment. For retrospective comparative cases serious after one surgery, BBF reattachment rate is 80.3, while BBF with the scleral buckle reattachment was 87.1. And if we're looking for the study that retrospectively and reported by Ikigari and his colleague showed that the screen buckling plus BBV resulted in greater success, single operative anatomic success outcome than BBV alone for primary retinal detachment repair. So single surgery success rate in BBV is 81, and for BBV and scleral buckle is 92 with significant B value. Phakic eyes achieved greater surgical success with scleral buckle plus BBV. And in eyes with posterior chamber intraocular lens, achieved similar results with both methods. This is one of my patients who is presented with retinal detachment and BVR, and you look how it is the complexity of this retinal detachment, and we are looking for the break. It is in inferior areas here, which is large heart shooter, and you know that inferior break retinal detachment is one of the challenging cases. So the vitrectomy was performed as usual. We did scleral buckle encircling band and put it in place. And after completing that, we get the small gauge parasaplana vitrectomy, and with usual core vitrectomy, extending to the periphery as much as possible. Then the vitreous stained with the triamcinolone assisted vitrectomy to make sure that no residuals. As you see, we did that, the posterior hyaloid, get it in, completed the vitrectomy, and putting perfluorocarbon and draining through the pre-existing break, air fluid exchange, laser were performed. I prefer some cases that to do 360 degree, and after that, with air fluid and removal of residual perfluorocarbon, I adjusted the scleral buckle completely, and then silicone oil will recede. Post-operatively, this patient picture like that, and being attached for a long time until silicone oil removed, and continue with good visual recovery. Another patient, young patient, who is having chronic retinal detachment, and the same procedure were performed with placing the scleral buckle, and then small gauge vitrectomy 23 performed. Vitrectomy, and you have to see here, there is an inferior fixed fold with BVR. Complete the vitrectomy. Again, see the break. Trying to remove the retinal brain and the epicenters here. Continue the vitrectomy, then triamcinolone were used to make sure that about posterior hyaloid, that completely removed. Then perfluorocarbon, filling the eye to make sure that the retinal laser were performed around the breaks, and then 360 degree. And the surgery completed as usual. And post-operatively, the retina nicely flattened, as you see here, the buckle in this area, with little bit present of cataract. So in conclusion, small gauge vitrectomy becomes increasingly standard procedure for treatment of primary retinal detachment by shortening operative times, lowered rate of post-operative inflammations, wide-angle view system that enhancing the surgeon confidence, hastened better visual recovery, and the improved success rate of small gauge vitrectomy for treatment of primary rhegmatogenous retinal detachment is contributing to the function of vitrectomy, which improves peripheral visibility and reduce the occurrence of BVR. Combined BBV and scleral buckle surgery may be associated with greater single surgery anatomic success outcomes than BBV alone for primary retinal detachment repair. A decreased risk of retinal redetachment when compared to BBV for repair of phakic rhegmatogenous retinal detachment, especially in cases with severe BVR or inferior traction and with incomplete removal of traction. Thank you.
Thank you. Thank you very much, Dr. Hassan. While our next speaker, Dr. Adil Al-Aqili, sets up not your typical chronic endophthalmitis, can I maybe ask you a few questions, Hassan? In your practice now, in 2022, are you still doing buckles? Because يعني a lot of people now are shying away from buckle, especially in the era of refractive 2020, and then you put a buckle, the patient becomes myopic. In pseudophakic, I'm talking. So what do you think?
Actually, as you see in the study, that pseudophakic patient, small gauge vitrectomy is a highly success in these cases. So are not attending because they are able to reach the periphery and you do good vitrectomy in these cases. The debate is in the cases where there is an BFR cases, inferior retinal detachment, BFR, pediatric, hair, combining small gauge vitrectomy with the scleral buckle, the success rate is higher when you compare it with only vitrectomy. So this is where you have to select your cases.
Sure.
No one of us like to have a case and tomorrow with redetachment, BFR, and then will be the difficulties and losing the vision. So this is the area where, but the preferred procedure nowadays is
I cannot agree more. Okay, go ahead.
Can I ask a question, or Dr. Hassan? Sure. So you always do 360 laser for all the cases?
What's that?
360 laser?
Nowadays, I'm not doing
With
that.
a buckle?
Yeah, nowadays, no, I'm not doing that. But before with the 20 gauge, you know how much that we have the difficulty viewing the peripheral retina. You don't know, so we do it more securely. But even though there is some study shows that parasaplana vitrectomy, in small gauge vitrectomy with 360 increase the success rate, anatomical success rate, even though nowadays. But actually now I'm more selective because I can see very well. Nowadays I'm using your technique, screw buckle, guided the chandelier, which is, I found it very, very well, helpful to discover invisible break just only with indirect ophthalmoscope.
Thank you. It's not my break. We are not my technique. We just adopted it from you. Thank you very much. Can we start? Okay, so first of all, I would like to thank Dr. Al-Amri for inviting me to this talk, and happy to be with the rest of my colleagues here with you. So this is a case of a 16-year-old who had panuveitis with a history of cataract surgery 10 years ago. He developed a vision of hand motion, and he did not respond, though he was started on systemic and topical steroid. And this is the picture. You can see here this typical plaque behind the posterior capsule with hypopyon. He underwent the workup. It was negative. So we took him to the OR, and we started the case with a diagnostic using the cutter to aspirate vitreous and some of the material of the posterior capsule in order to culture it, and then carried on with our vitrectomy. It was a standard vitrectomy where we did complete vitrectomy. We found that actually there was a PVD because the patient had vitrectomy done when he was younger with an anterior vitrectomy. But you can see those like they're snowballs material that's accumulating in the periphery. Despite that, we continued to remove as much as we can, and we looked at the periphery. And at the end of the surgery, it seemed fine. We concluded by partial air fluid exchange, and we injected vancomycin and ceftazidime. This is our broad-spectrum antibiotic that we use. The results came with an uncommon organism, Bacillus licheniformis, with staph epidermidis. And it appeared that the antibiotics in this situation were sensitive to the organism was sensitive to the antibiotics we gave. Patient reported that the vision improved. Actually, he said even better than before he had the infection. However, in 4 months, the patient comes back with another attack, and the vision was counting fingers at this stage. So we decided to go the second step and remove the IOL and also remove the whole capsule. Surprisingly, although this was almost 8 years ago or 9 years ago, the IOL came easily to the anterior chamber, and then we cut it and removed it. Although recently I started to use another technique where I don't cut it, I just fold it and pull it out. But this was what I did at this stage. After we removed you can see we're cutting here the IOL in half and then removing it. We had to put some iris retractors because of the pupil was actually narrow. And after we removed it, we started with our capsulotomy. And again, we can see that the same material we described earlier is here. It was really getting a little bit suspicious that this might be some underlying uveitis there that we're not actually aware of. However, we carried on with our plan, removed the whole capsule. Under direct visualization, we indented and actually made sure that we remove everything. And we shaved also the vitreous at the end of the surgery. So it was an uneventful surgery. At the end, we also injected vancomycin and ceftazidime. And the patient actually responded well to the treatment at this stage. And it seems like you want to actually do your best in order to make sure that there's nothing left from the capsule, because if we believe it's chronic endophthalmitis, this is the cause of the problem. And as I mentioned earlier, the patient seemed to recovered. The eye was quiet for a while until he came back 3 months later. And it seems like it's like a never-ending story, another inflammatory response with some hypopyon here. Tried to clear the anterior chamber, looked at the back. It seems like the same presentation that we're having. However, when we started to look at the periphery, it seems that we have this collection of pus around the vitreous base in that area. So we went and did the routine. We tried, again, used iris retractors, removed, carefully tried to remove and shave that remaining pus and vitreous that's an amalgam over there. But we were very careful not to create any breaks, because you don't want to create breaks in a young patient in an inferior retina with no lens. Definitely, it's a recipe for a disaster. Frankly, fortunately, we were able to remove the whole this part of the vitreous base with that collection of pus over it. But we wanted to do something extra just to make sure that this never happens again. As you can see now, we're trying to even indent and look behind the iris, clear whatever we can do. And what we did here is we actually got the endoscope and examined the periphery of the retina and behind the iris, just to make sure that there is no residual capsule, because the capsule here is where we think the problem is coming from. And looking here at the area of our trocar's insertion, it seems that there are some residual membranes. Maybe these are things that are related to the recurring inflammation. So we tried also to cut as much as we can, clear up the area. And at the end, it seems that the patient was, at the end of the surgery, we did not create any breaks, so we were satisfied with the situation and ended up injecting again. So we inject again vanco and ceftazidime. And looking at, also tried even to look at the angle from here, and it seems that there's no remaining collection of pus over there or any capsular material that can be removed. Again, we took the culture and we isolated the same material, so we were sure we're at the right track. The patient recovered well with the treatment, and we kept on following him for another year. However, in a year, he developed an epiretinal membrane. This was a quiet eye with an epiretinal membrane, so we went in and removed the epiretinal membrane. And it's now, after a year of the epiretinal membrane removal, the patient has a quiet eye for almost 1 year. There is no, the best corrected visual acuity was actually 20/40, so it's very encouraging. The patient is actually asking for us to do something now that he's quiet for some time for him to improve his vision. He's not very happy with wearing contact lens. The eye the ocular surface is not very ideal. Again, this is the picture after we remove the epiretinal membrane. the macula is free of any membranes. The eye seems to be quiet for some time now. So when we think about cases of chronic endophthalmitis, we think about the typical organisms. We always think about P. acne as the culprit in most of those cases. It actually causes around 50% of these cases. And usually those patients can present with gram-positive organisms such as the one that we had. It's a little bit less common than P. acne, but it's something that's been reported. However, having a mixed organism like we had the first time, can carry different prognosis. Fortunately for us, it seems that the patient was responding well. So again, with P. acne, we know that the response in terms of vision is better. Rarely that you end up with no light perception. It's only 12%. And in terms of the treatment, we know that we have sometimes a stepwise approach where we actually go do an injection, and then if it doesn't work, we do a vitrectomy. However, in our this situation, we decided to go with a vitrectomy and posterior capsulotomy. However, what we know now, or it's almost commonly described, that you still have around 30% recurrence rate if you end up having to do vitrectomy, posterior capsulotomy. But if you go in and remove the whole capsule, you do you remove the IOL, the recurrence rate is usually very low, around 5%. But doing that, in our case, we ended up still having to go another time. So you want to make sure that you also shave the vitreous as much as you can without creating any breaks, because this can be a cause for presentation like this. We found only a single report of Bacillus licheniformis as a culprit in such infection. This was also, like our case, a delayed presentation 10 years after cataract surgery. The patient also needed 2 surgeries. The first surgery, she responded well, but then she had another attack 1 week later, and they ended up removing the IOL. But it's very important to know that those cases can present similarly. You want to do vitrectomy, but it doesn't mean that every time you go in you need to remove the IOL. It's based on the discretion of the surgeon, I would advise. So my question to the audience and the panel: if now that he's 1 year quiet, he wants to do a secondary IOL, would he do it? And when will he do it?
Go ahead.
No, of course. I mean, if you think he's quiet and he's been stable, how old is the patient? Sorry.
He's almost 20.
Yeah, I mean, he's very young. Definitely, you don't want to leave him aphakic, and definitely, I'll go for a secondary IOL. Yeah, but the question is, what is the choice? Which IOL would you put?
I think it depends on your experience.
I mean, would you put scleral fixation or Yamani, or would you do artisan?
I think you want to limit the material that you're putting inside the eye, because you, as much as you can, you don't want to have a caveat for the material to grow again. I would say now that we have the newer kinds of IOLs like Carlevale, I would say this would be maybe one ideal option to use that case.
I do agree with this choice. 20-year-old aphakic, and for 1 year he's quiet. Why not? Patient, I'm sure that he will understand. And almost you clean everything. I don't think there is any more residual. But congratulations to manage such case, taking this long times, and vitrectomy, and but good thanks God, it is not fungal. So this is make it more reasonable that that we have antibiotic and functionally good for bacteria although it is rare case, I mean that pathogen, but by the end it's better than to be fungal. Fungal usually whatever you do is getting and you cannot control it. Dr. Abdullah?
For the vitrectomy, for the endophthalmitis, antibiotic, if not antibiotic plus vitrectomy, I will hesitate to remove the IOL. I agree with you. This is one single piece IOL. So put it in the sulcus, which is not the correct choice. But
Actually, it was in the bag, actually.
it was in the bag. So you remove.
Yeah, there is
okay.
monosulcus.
Okay, so if it's in the bag, I would maybe agree with you for removing that. If it was in the sulcus, I wouldn't remove it, honestly. If I remove the bag, the IOL from the bag, why I remove the rim of the capsulix? I can make removing the center of the anterior capsule or posterior capsule, leaving a rim in which I can insert a three-piece IOL in the
Dr.
sulcus. That will be
Abdullah,
much
it has
easier.
been clean everything.
Huh?
There is no more
We
bag.
removed
there is-
everything.
No, you,
but it
you
still
remove.
recurs.
Yeah, but no, I'm planning from the choice from the beginning because I saw you eating all the rim of because you are worried of the recurrence of the endophthalmitis, which is a reasonable act. But to be honest, I don't think the rim will cause increase much of the infection. Maybe the capsule, yes, because
Generally, I would agree.
It has
Yeah, that's-
IOL in it.
Thank
Yeah, thank you, Dr.
But very
Adil.
nice
It was
choice.
great
Thank you.
presentation. Our next, presenter and speaker is Dr. Saad Wahib. Dr. Saad Wahib is senior consultant in King Faisal Specialist Hospital and Research Center in Jeddah. He's the, chief of the division and is usually having, interesting cases.
Yes.
He will talk about post-operative endophthalmitis. Is EVS, still applicable or not? I'm doubt.
Yeah, I'll try to convince you it's not applicable in 2022. So along the same line Dr. Adil was saying, I'll take you through, can I get the next slide? No? ناحيته هو ها. Okay. So we agree that this is a bad disease. We don't like to see it, but unfortunately, you will be faced either from your own cases or from your colleagues. And I think the basic point here is rapid recognition, diagnosis, and early treatment. I will just skip this because I'm sure you're all aware of, the risks, the percentages, and the incidence has gone much less with smaller cataracts and improved in the techniques. And, the organisms have been shown in the previous speaker and the risk factors. And one thing I want to say, and I don't know if we have any cataract surgeon in the room, if you have a problem, if you get a rent in the posterior capsule, please put a suture. I don't know what's wrong with some cataract surgeons. They don't like to put a suture. It's an ego thing, I think. So I think if you get a posterior capsular rent, you increase the chance of leak and complications. Single suture is not going to make a big difference. Now, symptoms is mainly a clinical diagnosis. You know about the treatment. I want to take you through the AVS study. Now, this is a study that was done in the 90s, so more than 20 years ago. And the study was based on the old technique. I mean, I was trained at that time, and we were only doing 20 gauge at that time. And the viewing system were very bad. And at that time were the handheld Macumer lenses. Some of the older people, Hassan might know that. Maybe the younger generation have not seen these things. So the whole idea behind the study was to convince you that if a patient vision is better than hand motion, there will be no difference. But if the patient vision is light perception is or worse, then you would consider going for a vitrectomy. I would tend to say the opposite. You want to go for early vitrectomy. And the idea behind doing a vitrectomy is to debulk the vitreous. You remove all the toxins. You remove all the bacteria. You have good amount of material and specimen for cultures and sensitivity, and you definitely improve your visualization. What are the issues with vitrectomy in 2022? Not much, really. Maybe the cost, maybe the fact that you have to go to OR, but otherwise, it's a very safe procedure. So again, just to, sorry. Yeah, so I think in 2022, there's been a lot of studies. There's a big study coming from the US, I think Alabama, that looked at their 20 years or 10 years experience. They've seen more than 60 patients where they've done early and complete vitrectomy compared to the standard tap and inject way, and they've shown that more than 80% of their patients will have more than 20/40 vision, and more than 50% of their patients will have more than 20/100 vision, which I think is great when you talk about such a bad disease. So let me just share with you some of my personal experience. This was an older gentleman who's been referred to me from a very good cataract surgeon I know personally. This is the patient picture pre and the first day post-operative, and the patient was LP, and the first day post-op he was 20/60, very happy, he's doing very well. But then within a week, the patient came back with LP vision. Now, interestingly, this guy did not have a lot of pain, was not complaining, but maybe because he has been LP for such a long time, he thought that this was just part of the, the recovery. So when we saw him, it was a little bit late. We were during the COVID time, so there was no doubt about the diagnosis. At this stage, we decided to admit him. I injected the patient at the same time. I told him that we have to do the COVID test because we could not get him in the hospital without that, and he will be admitted overnight. Early morning, we will go for surgery unless I see major improvement, which I did not, as you would expect. So the whole idea behind doing early vitrectomy for these patients is to try, again, as I said, to debulk the vitreous as much as you can. Now, you do this in a stepwise manner. So you treat the anterior chamber first. You clear the anterior chamber. If there is if there is hypobion, if there is any thick stuff, you remove it, and then you try to manipulate the iris to get a better vision. If there is a membrane on top of the eye well, again, you try to remove it. So you try to prepare the anterior chamber. A trick I learned is to, if you want to get a good sample and you're worried, then you can put some air in the vitreous and do a vitrectomy. You tend usually to get very good samples. I do not remove the eye well, but I do a good generous posterior capsulectomy, and then I focus at the back of the eye. Now, the traditional teaching is when you're doing vitrectomy for endophthalmitis, you just do a core vitrectomy and you inject antibiotics and you leave. This is not the case. You really want to do more than a core vitrectomy. You want to remove as much of the vitreous as you can. You want to try to induce a posterior vitreous detachment, but you have to be very careful because you're dealing with a very thin, necrotic, atrophic retina. Now, why are we doing this? Because it has been shown that the longer the contact between the abnormal infected vitreous with the macula, the more chance that they will develop endophthalmitis-related retinopathy, which you can see when you operate on these patients. The retina looks really bad. Especially when you do the periphery, you want to be careful. But again, you try your best to take as much vitreous as you can. For the sake of time, I'm going to move to the next slide. The patient did extremely well. Within a week, his vision did improve. The above pictures are at the beginning of surgery and at the end of surgery. And he's really recovered very well, and within a month, his vision has become to 20/40, and I've been following this guy up. I think after 6 months, his vision came to 20/30. I doubt you would have reached this vision with TAB and inject. So you definitely want to consider early surgery. This is another guy who's again referred to us with acute postoperative endophthalmitis. Same picture. You start by clearing the anterior chamber. You remove hypobion if there is. You do good capsulectomy. I have not been removing IOLs. I think Adil case is different. And then again, so I think it's going to be the same. I just want to show you, so you remove the cyclitic membranes, and then you can see how bad the retina looks like. Very hemorrhagic with all this white stuff that you try your best to remove. And again, if you cannot induce a safe PVD, and I stress the concept of a safe PVD, because if you treat it like a regular eye, you will definitely end up with trouble. Then what you at least can do is vitreous phase fenestration, where you make holes in the vitreous phase, allow the antibiotics to come into the inside the eye, and you go to the periphery again, you inspect the periphery very well, and you do more than a core vitrectomy, and the patient absolutely did very well. I've been seeing this patient now for almost a year, and his vision did improve again to 20/30 or 20/40. So practical points, In my experience, 23 is better, but I think 25, 27 will do the job. You do anterior segment clearance first, you do an AC wash, sometimes you have to remove the epithelium. When you do anterior chamber work, please remember to keep the infusion off, otherwise you will run into trouble. If you can't get a good sample, put some air in the vitreous. You do more than a core vitrectomy. Allow the antibiotics to go to the back by doing a good generous posterior capsulectomy. I remove the posterior capsule. I haven't been removing IOLs. You induce the PVD or you do at least fenestration. So the take-home message is high index of suspicion. Acceptance is a big issue because some of the anterior segment surgeons, they sit on these patients. They see them, they think it's sterile, it's a little bit of iritis. The earlier they send the patient, the better the results. You talk to the patient about the risk. It's an unfortunate, but it is a genuine complication that can be seen. I think the early and aggressive treatment is the way to go, and steroid will help to control inflammation. Some people don't like to use steroid, and I have been in practice for a while, and I have to say I've been less aggressive with almost everything else I do except endophthalmitis. And I think with endophthalmitis, the earlier you go, the more aggressive you are, the better results these patients have. Thank you very much.
Thank you, Dr. Saad. Great, amazing presentations. And actually, such cases that you have to have high, index of suspicions, which make, the diagnosis early and the interventions. Your question that endophthalmitis vitrectomy is still applicable or not, we need to answer it. Is it still applicable or not?
I'd like to hear from the audience what they think.
Do you follow the EVR study, Doctor?
Yeah, so I still use the EVS study a lot, and I have had a great success with intravitreal antibiotic tap and inject. And my routine injection is usually Vanc, ceftazidime, and dexamethasone. And I think, I don't know, but I think the main reason I have such a good results, I think adding dexamethasone implant. Additionally, as far as the surgery goes, over the years I have done a lot of endophthalmitis cases, and with time I'm actually becoming more cautious and more conservative. And I kind of feel that, I've had, I've been bitten a few times where you kind of want to shave and do the best, and then it's just a tiny bit of tear or a hole, and then you get complete total RD with aggressive PVR, and it's a nightmare dealing with that patient, dealing with their post-operative complications, counseling is just a nightmare. And I've had great success with the tap and inject, and it worked well for me, I think.
Yeah. It's a great comments, but still I think so. By the time being the vitrectomy machines, it's not the same as it is 20 years. Yeah. Even though if you look for EV, the endophthalmitis vitrectomy study, their antibiotics that are using is not the same as that we do now. We have dexamethasones, we have all. I would modify it rather than to say, I cannot apply it. If I'm in the place, I will say that I don't have vitrectomy by the timing, or the patient still cannot be prepared for surgery within hours. I can go with the intravitreal taps and injections, and then go for vitrectomy, small gauge vitrectomy, 25 gauge. You don't need to go for everything to remove, all that. It is debulking the vitreous, injections, and go out, regardless of the status of the retina. So newly that we have that, we ensure that cases that having this vitrectomy early, it's really having more, especially with very bad types of organism or foreign organisms.
If you
During my residence in LV Prasada Institute, that is 20 years ago, we are very strict to EV study. And we just, after we see the red reflex clearly, we go out and we inject antibiotics. Now, we are still doing a lot of vitrectomy by this new, very small gauge, 23 or 25 sometimes. But I want to make sure that those who will do that, they should do it under a very precautions, because the retina is so delicate, and they should not go for posterior vitreous detachments. And never, just to clean at least most of the products or the exudates, and they should not go for that. I am not using dexamethasone now. Since that time, I am not using it. For the antibiotic, I am still using vancomycin as the main, and we changed actually for amikacin at that time to another very new antibiotics. Steroid is mandatory. I think steroid is a main issue in doing vitrectomy for endophthalmitis.
Steroid usually for the acute post-op of cataract usually. This is where we are using. Dr. Abdullah?
Yeah, just fast comment. Actually, I totally agree with you, Doctor. Adding dexamethasone, I think it should be considered, because the rhythm of cataract surgery just increase a little bit. The rhythm of endophthalmitis post-ophthalmology surgery increase a little bit, but increase a lot of cases after injection. And actually, endophthalmitis after injection is even worse, because you bring the organism closer to the retina. So because of the injection is biologics, most of it will have intraocular inflammation, vasculitis, whatever. You can get confused between early catch-up of endophthalmitis and just an autoimmune intraocular inflammation post-biologic injection inside the eye. So adding dexamethasone will treat both at the same time. So I already started dexamethasone antibiotic, then I stopped dexamethasone, then after a few years I regained back injection with dexamethasone, and I feel comfortable in that. Dexamethasone with the antibiotic, there is no afraid of it suppressing the inflammation.
Dr. Saad, what do you think? You are the one who is presenting.
Sorry, Abdullah, you give dexamethasone in what, in endophthalmitis? Okay. Yeah. I don't have experience with dexamethasone implant. I give steroids, but I just don't want to put anything foreign in the eye at that stage. And I still believe you want to do, whoever said that he doesn't want to do PVD, I think it's a key. Decreasing the contact between the infected vitreous and bacteria and toxin and the macula, I think is very key if you're considering patient vision. We have seen 20/30, 20/40, 20/20 vision post-endophthalmitis, which is, I think, unheard of with the tap and inject. It might work, but I think you have a better outcome, and especially with the advancement in technology, in a smaller gauge, wide field, I don't think there's any excuse at this stage. Thank you.
Yeah, thank you all for this, and we have to move to the next later on, inshallah. Can we go, Doctor, for next speakers? We have Dr. Yahya Zahrani. He's a senior consultant in King Fahad Medical City. And Dr. Yahya is a vitreoretinal surgeon, uveitis, and oncologist, and he's gonna to give him a talk about suprachoroidal hemorrhage with retinal detachment, what to do. Dr. Yahya?
Thank you, Dr. Hassan. I would like to thank the organizer committee for the invitations. Before I start my talk, I would have one comment for the endophthalmitis cases. So we have facing a lot of endophthalmitis cases who came to us from remote area. So I have a message for our colleague in cataract surgeon. If you have endophthalmitis, please inject the patient, then send him to us. Don't send the patient. It will take like hours and hours to reach our hospitals. So he might lose his eye. So the message here, please give endophthalmitis, then send. So this is the only message that I would like to say. So my talk today is real suprachoroidal hemorrhage, which is a very devastating complication that we don't like to see in our patients. So no financial interest to disclose. So as you know, the suprachoroidal expulsive hemorrhage is very rare, but is very devastating and threatening the vision in those patients. So they have been classified in several ways, like spontaneous choroidal hemorrhages, perioperative, traumatic, and the preoperative, the most commonly that we encounter can be classified as intraoperative, which is commonly facing it in the cataract surgery, or postoperatively, which is frequently seeing after glaucoma surgery. So the incidence is highest after the glaucoma surgery compared to the other intraocular surgeries, and the lowest in the cataract surgery. And this is the risk factors that we might encounter for this for the choroidal endophthalmitis. Sorry, for the suprachoroidal hemorrhage. So the systemic risk factors, some of them modifiable, and some of them you cannot modify, like the advanced age of these patients, glaucoma patients, etc. So the most important risk is sudden hypotony. So for those patients, those physicians who are dealing with the glaucoma patients and they want to do like intraocular surgery, please decompress the eye slowly. Don't do fast decompression of the eye, otherwise you will shear the ciliary artery and they will end suprachoroidal hemorrhages. So as you know all, if you know the sign and symptom of those patients, if you encounter sudden shallow AC or you lose your red reflex during your cataract surgery, you have to be cautious. So you have to think a lot before you proceed with proceeding with the cataract. So you have to make sure that you close the wound as soon as possible if you encounter choroidal hemorrhage. Otherwise, you will end with the extrusion of the intraocular content. So I will share with you one case that's, he's like a 76-year-old male patient. He was operated by one of my friends in the private clinic, and he was doing like straightforward phaco surgery, and suddenly he lost his red reflex, and then he just removed all the cortical material, and then he closed the eye, and then he take him to our hospital. I was on call at that time, and when we saw the patients, he has very light perception vision with the 40 pressure. And this is his ultrasound on arrival. So can we show hands? Who will do immediate intervention and drainage of the choroidal hemorrhage, and who will observe? So who will do the immediate intervention? None. So who will wait? Who will observe? Almost everyone will observe. So good. So this is what we did actually in these patients. So my colleague was pushing me, please go ahead and drain, try to regain vision of this patient. I told him, no, I will not intervene. Let's observe. So how long you will observe these patients? So less than a week. Okay, 1 to 2 weeks. Or you guide your waiting by ultrasound. I think this is the most critical part, is to wait based on the ultrasound. So actually this is what we did, and then we repeat the ultrasound like 8 to 9 days later, and you can see the huge choroidal hemorrhage that he has. And you see the difference between the hyperechoic and hypoechoic. Now the clots start to lyse. Huh? If you compare this to this, you can see the difference. So this is hyperechoic compared to this hypoechoic. So if you go intervene immediately, you will face with difficulty to remove the clot from the suprachoroidal space unless you inject TPA, and you might get more bleeding. So I waited. Then at this point, when I repeated like 8 days later or 9 days later, I faced this retinal detachment. So the question come here. So what to do? Are you going to do just external drainage? Are you going to drain and then do vitrectomy at the same time? So who will just do the drainage? Ahmed. He's the only one, okay? So who will do drain and then do vitrectomy at the same time? So everybody rushing to do vitrectomy. Okay, very good. So actually what I did, could you play the video, please? Video. This is not the time. What is this? We'll see it now. So you can see how huge is the choroidal detachment. So we decided to go in and just do the scleral cut down. So I don't go really back like 7 or 8 millimeter. I just do it like 4 or 5 millimeter maximum from the limbus. So we cauterize. We do AC maintainer is very important step in draining those patients. We have to have the high pressure inside the eye to allow for the hemorrhage to drain. And then we do the scleral cut down. Again, this is controversial, doing radial, doing circumferential. I like to do circumferential. So actually my fellow was doing this case. I was watching him, observing him. So you can see the hemorrhage, how it's come. So you have to be very slowly cutting the sclera till you get the lamellae. You can see a lot of hemorrhage coming out now. If you intervene immediately, you will not be able to get all this hemorrhage. You'll have hemorrhages already clotted. And watch the red reflex. You can see the red reflex start to appear now. You see a lot of hemorrhage coming. I'm not sure if the red reflex is clear. So choroidal getting smaller and smaller, and then you can see the red reflex start to appear from, maybe you can see it here. So yeah, you can see the red reflex start to appearing. And you can see the residual choroidals. We keep draining as much as we can. So on table, I examine. I use the indirect ophthalmoscopy, then examine the patient carefully. I look for any break peripherally. I didn't see any. So the fellow was eager to do the vitrectomy, so I say no vitrectomy, just choroidal drainage. So we close, and then, so I give posterior subtenon triamcinolone. Then I saw him next day, he looked like this. So there is RD, Dr. Hazzaz, yeah? So then I decided to observe, again, a lot of fluid. And you can see most of the fluid superior with the choroidal detachment still there nasally. So again, I decided to observe. So this is the OCT 2 weeks later. 4 weeks later, he's better. 8 weeks later, he's completely flat. So understanding the pathology is very important. Doing surgery is not a fun. So you have to be careful when you go in. You might ask for trouble. So if you go in to fix this retina, you have to create retinotomy. You have to drain the fluid. You might get BVR. So you go in trouble. So 8 weeks later, he has this retinal completely attached. Then 3 months later, I told him I bought sulcus IOL. So we staged the procedure. He's 23rd division now. And the message here is you have to understand the underlying pathology before you go in. You have to keep the pathology in your mind. So what we are dealing with. Are we dealing with rheumatogenious? Is it exudative? Then accordingly you manage your patients. And very important to you examine the patient to make sure that they are dealing with which type of detachments. Thank you very much.
Thank you, Dr. Yahya, for presenting such great case, complicated. Having the issues that when you are having the case for first times, it is too difficult to decide unless you follow the standards or even the guidelines. So waiting, looking to having the ultrasound, looking for the liquefations of the suprachoroidal, clotted hemorrhage is really effective. Getting oxidative retinal detachment versus rheumatogenic retinal detachment is really a big issue in these cases. Sometimes that external drainage to not able to take everything from the, from one cut down in the sclera. So might you need that, especially using, the cannula of the small gauge, which could be helped in such cases with having infusion in and. So the question, is that advisable, not advisable? I think so. The surgeon who's experienced can decide on the spot.
You mean using the cannula for draining of the suprachoroidal?
Yes, the trocars of the, the trocars of the small gauge helpful to drain. So it is the experience and how much cases you deal with. So I would not say 100% no vitrectomy in these cases if you are being experienced and because putting air fluid inside the eye will help to push, sometimes this, fluid and blood out, even though. But really, you did the right for the patient, and the result is showing is. So what do you think if you have doubt about retinal detachment and could be rheumatogenious because the patient already having surgery and the possibility of RD is there?
Yeah, so this is a very important question. So the careful examination is really very critical in these cases. So we have the eyes pressurized, we have AC maintainer, we close the sclerotomy wound, and then you can indent, you can examine the case properly. So if those cataract surgeons, those who are fishing after the dropped nucleus, etc., they might get a giant retinal tear. So you have to be very cautious also in examining the retina. So I always saying observation is not a bad option. So doing less is better for those patients.
I agree that. Questions, guys? Please, Dr.
محمد توفيق will do vitrectomy أكيد.
No, I just I have two important questions.
Yeah, sure.
Is there any type of suprachoroidal hemorrhage you need to intervene without a chance of follow-up, or every case of suprachoroidal hemorrhage you need to have a chance of intervention of observation?
In every case, you give a chance for observation. Every case, you give a chance for observation, or there is some cases or type of suprachoroidal hemorrhage, you must intervene once.
For retinal detachments.
No. You tell me, what is the type of suprachoroidal hemorrhage cases you will intervene once?
For the choroidal hemorrhage.
Yeah.
So for the kissing choroid, you have to intervene immediately. This is the one options. But in this case, so by the way, most of the choroidal hemorrhages, if it is peripheral and small, it will go by just medical treatment. So you don't need to intervene surgically. But here, as you can see there.
I didn't answer about you intervene surgically or you follow up. You tell us that if you have a case of suprachoroidal hemorrhage, you need to observe for 2 weeks, 1 week, don't intervene in the same day of presentation. If there is any type of suprachoroidal hemorrhage, you must intervene in the same day of presentation, or every case of suprachoroidal hemorrhage, you need to observe for 1 week to 2 weeks. This is my question.
I always observe.
Whatever.
Always observe. I don't intervene immediately. So you have the option as a retina surgeon or glaucoma surgeon can do scleral cut down. But I don't recommend. If you have expulsive hemorrhage on table, please close every wound. Close.
Agree with Dr. Yahya. No immediate.
Yes, this is my question.
Because you cannot, this is clotted blood. And whatever you do, it will not be drained. So waiting, he said that from 10 days to 14 days, I think so.
Yes.
1 to 2 weeks.
Some people, they using, steroids.
So this is the second question. What you are doing in the medical treatment for
no strong evidence showing that steroid will, that 100% will help in this patient. But if there is a lot of inflammation in the eye, and
so steroid, anti-glaucoma, this is the medical treatment you give it to the patient for this 10 days or 2 weeks.
We have echo sometimes, we cannot hear what you said, doctor.
You mean
the medical treatment that you did giving to the patient?
What medical treatment
Yes.
you mean? So I usually give systemic steroid for those patients and topical steroid plus cycloplegic. So this is what I usually do for those patients, plus anti-glaucoma medication.
Plus anti-glaucoma.
If he has high pressure, of course.
We have a bad echo here, so that...
I can't hear well. Huh?
Yes, great case. That's fantastic. I think the second indication, probably to answer Mohammed's question, for early intervention, other than kissing choroidal, is if the patient is in severe pain and the pressure is very dangerously high and cannot be decreased. And one technique I learned, if you need to intervene early before the blood is liquefied, is to inject suprachoroidal TPA. Which is really nice. In 2 hours, the blood is liquefied and you can drain either with a cut down or with a trocar and venting. But I agree with you, it's best not to
totally
operate
agree.
on these
It's
cases.
high pressure and you cannot control it.
In case of non-kissing choroidals, and the pressure is reasonable, would you interfere?
No. As I told you, I almost always observe those patients. I have a lot of patients who had traumatic choroidal hemorrhage and non-kissing choroids. I just observe them and they clear up with time without any surgical intervention.
This is what I'm saying, that ultrasound guided is the best for these patients. Thank you, Dr. Yahya. It's a great case. We are going for the next speaker with approach to submacular hemorrhage, Dr. Muhammad Al-Hazzazi. Is a senior vitreoretinal consultant and uveitis consultant sometimes in National Guard Hospital in Riyadh. Dr. Muhammad is the head of the retina units there. Dr. Muhammad, what you would like to say?
Thank you very much, Dr. Hassan, for the introduction. I think this talk is just like a consolidation of what the morning session was about, which is suprachoroidal hemorrhage approach. So why do we need to intervene in suprachoroidal hemorrhage? Because the photoreceptor damage can happen with multiple things. One of them is the stripping of the photoreceptor's outer segment, secondary to clot contraction. Also because of the toxic effect of iron and the diffusion barrier between the RP and the photoreceptors. Experimental studies showed that the damage to the photoreceptor can happen as early as 24 hours. However, we know that a favorable outcome can still surgically, we can have a good outcome if we intervene within the first 2 weeks of the incident. The etiology of the submacular hemorrhage are numerous. The most we see in our area is the choroidal neovascular membrane or BCV and probably trauma. What are the factors associated with poor outcome? Presence of choroidal neovascular membrane, thick hemorrhage, more than 400 microns, AMD etiology, or a large hemorrhage. Some of the paper has documented that the shorter the radius of the hemorrhage, the better the outcome, and also the intact of ellipsoid zone and epiretinal membrane will give also a good outcome. In OCT, there are a few things that you have to look, after in those images. The first thing is the level of the submacular hemorrhage, and this is very important because it tells you whether you will intervene early or you may just use another modality other than major surgical intervention. The second thing is the measurement of the height of the submacular blood. The third thing is the reflectance, which is an indirect way of telling whether the blood is more of liquefied blood or it's like more of clotted blood. The options to approach those patients, starting from observation or treat the underlying cause only by using anti-VEGF, pneumatic displacement using a gas bubble in the vitreous cavity, or pharmacological clot lysis using TPA, and there is also a lot, a negotiation and preference whether to go intravitreal or subretinal. This case presented with 2400 vision due to submacular hemorrhage. However, if you look at the bottom OCT, you see that the blood is mainly in the sub-RPE space. So anti-VEGF enough to help this patient to recover his vision over 5 months. Okay, another patient, trauma with submacular hemorrhage. Gas, since we knew that the pathology is just only trauma, so pneumatic displacement of the blood from the fovea area will be more than enough. And this is what happened. The patient improved immediately. A young patient, we don't know yet what is the pathology. This is a nice photo from Eden machine. You can see in the OCT on the right side that there is subretinal blood. However, the majority of blood is in the sub-RPE. So we decided to go only with intravitreal aflipercept plus intravitreal TBA on day 1. Then 1 day later, we injected the patient with the SF6 bubble. And this is his baseline photo compared to 1 week. His visual acuity improved to 2100. You can look at the OCT on the left side after the patient presented 1 week later, and you can look at him 2 weeks later. The RPE start to flatten, and the blood in the subretinal space almost disappeared. This patient presented again 1 week later. You can look at his old photo. You can discover the dehemoglobinized blood, old one, if you compare it with the previous photo. This patient have another attack. However, this time, for the same patient, has different approach. So instead of going for pneumatic displacement or injecting him with, intravitreal TBA, we just injected him with intravitreal aflipercept. And at this stage, we did an ICG, which showed very clearly a small polyp just superior to the fovea. Patient received a laser treatment to that area and he did very well. This patient, 72-year-old male, he was doing excellent on monthly anti-VEGF. He is an AMD patient. He disappeared for 6 months and he came complaining of both eyes. The right eye, luckily, subretinal fluid accumulated. While in the left eye, you can see there is a submacular hemorrhage. But if you look at different cut, and this is why the OCT is very important, just at the fovea, the subretinal blood is, if you just take the reflectivity into consideration, it is very minimal blood at the foveal area exactly. So again, the same approach, intravitreal Eylea given plus intravitreal TBA, followed by SF6 bubble 1 day later. You can look at the subretinal space, almost no blood. And this is him with improvement of his visual acuity into 20/60, 2 weeks after the intervention. This is another patient. I just wanted maybe to show you that most of cases that I have encountered, and they have like vascular origin, like diabetic or vein occlusion, most of them, they ended with a foveal scar. I don't know if this is really common to be seen by any of you. So let's just highlight what has been discussed this morning. The surgical technique, whether it's a 38 or 41 flexible cannula with a TBA 25 micron in 0.1. Now, whether to go for a multiple bleb or single bleb, the maximum fluid should be injected not exceeding 0.5 ml in the subretinal space. Whether to inject a bubble in the subretinal space or no, that will be for the discretion of the physician. So why we always say that subretinal TB is almost equal to intravitreal? Because one of the papers showed that 100% reduction in the subretinal blood and the subretinal injection compared to 97. So almost we are talking about a very excellent outcome. And also another paper showing that similar visual outcome at 6 months comparing intravitreal compared to subretinal TBA. And this will draw the conclusion that sparing the patient from a complication like RPE rip or macular scar formation can be avoided by less invasive procedure. So the take-home message, no clear guidelines or specific technique to treat the submacular hemorrhage. The aerial intervention, usually the better the outcome. The treatment strategy depends on how large is the macular hole, the availability of the equipment. Instead of waiting for a supply or equipment to come to OR, you may have available instruments in your clinic and probably the outcome will be the same. The time of presentation of such patient will be very important to determine whether to go for which type of approach. Finally is the subretinal versus intravitreal TBA will have the same outcome. Thank you for your listening.
Thank you, Dr. Muhammad, for really informative presentations. And I would like to look for Dr. Ahmed Salam, he's the expert of submacular hemorrhage, and open the floor for 2 questions. Dr. Ahmed.
No, this is a great presentation, and I share the same opinion with Dr. Muhammad that less is more, and intravitreal is more than enough. Even pneumatic displacement is more than enough. And best, to consider vitrectomy for extensive cases, and you can put the TPA intravitreal. So I totally agree with all what you do, really. I think this is very nice. My question is, when you do vitrectomy, do you do multiple blebs or single bleb?
Actually, it depends on how much the submacular hemorrhage. So, if you have already a detached retina with a large subretinal hemorrhage, probably creating one bleb is more than enough because you have already a detached retina. And you have already also a blood in the subretinal space. So again, respecting the space is very important to avoid iatrogenic break. Creating multiple blebs, I did not see it having any advantage if you have injected around 0.3 in the subretinal space. So again, the less the better.
I think the important point as well, which was mentioned today in the discussion, is to inject slowly because you want to avoid the risk of creating a macular hole.
Dr. Muhammad, I have a question for you. Would you change your, technique if you have large submacular hemorrhage related to AMD? Large, talking about large. You inject, some anti-VEGF, and you get in, you give intravitreal TBA, and then you will go to gas. Is there any difference between this such case and go with the subretinal injection of TBA, air displacement subretinally as well? Or
Thank you,
that
Dr. Hassan,
because
yes.
I'm expecting, there is with the large hemorrhage something could be changed or helpful for the patient.
Yes, again, I will do refer to the same, facts that I have shared with you. First, we have to agree that AMD usually ended by worse outcome because we have not only a blood in the subretinal space, no, you have another pathology which is a membrane that's growing in the same area. The importance of the OCT finding showing you how much the blood in the retinal space. If you look at the patient that I have soon, showed you the last case probably, from the first time you see there is a blood, but if you look at the OCT, it's mainly in the sub-RPE. So why do I need to rush? Because if you go inside, the area between the retina and the RPE is very thin and very short. So you may inject in the sub-RPE, and this will cause RPE rep for sure. And the complication will be more, and you are not treating the pathology because if the blood in the subretinal space, that's the time you think about toxicity to photoreceptors. If it's in the RPE, studies showed that there is no toxicity even if the blood stayed for a long time. Yes, Dr. Ayman.
Can you, doctor, shortly brief what you, shortly because we are
Yes,
running out of time.
when I inject, when there is a subretinal and subretinal pigment epithelial bleeding, when I inject subretinal TBA, I found the results are better than injecting intravitreal alone. Besides that, I inject SF6 half fill to the patient, and I let the patient just to lean forward a little bit. This is my experience, but definitely I've tried the intravitreal and it works very well. Thank you very much.
Please, yeah. You go ahead, please. Can you give it the mic, please?
You inject the TPA plus the anti-VEGF in one session, and then you inject the gas bubble after 1 day. Why not to do the whole thing, even waiting like half hour or something, and give everything in single session? And then you should not, it's not necessary to position the patient for 24 hours. I mean, if you want to wait for the positioning, you can inject the gas bubble in the same session, and then you can position the patient after 24 hours, just saving the multiple sessions.
Yes, the idea that we injected the intravitreal TBA and we wanted to give it some time to start working to liquefy. Better than keeping the patient for the whole day, he will receive just only the intravitreal TBA along with the intravitreal anti-VEGF, And with this amount, you need to do paracentesis to decrease the pressure because you are almost injecting 0.15, so which is a large amount. Then the second day, by that time, the pressure should be already equalized, so you inject an expansile bubble in the vitreous cavity, and you ask the patient to have the face down position. So with the first day, you give a chance for the TBA to be close to the area to liquefy it. By second day, almost you are quite sure that the blood is already liquefied. If you ask the patient to have like 5 to 6 hours a day of face down position, will be more than adequate.
Yeah, thank you, Dr. Muhammad. We are running short of times. Our next speaker is Dr. Abdullah Al-Gahtani. He will give talk about volcano TRD. Dr. Abdul Gahtani is a senior veterinary consultant, uveitis and ocular oncology in National Guard Hospital in Jeddah. Dr. Abdullah is a really active veterinary consultant in Saudi Arabia in the field of scientific meetings and presentations. Dr. Abdullah.
Thank you, Dr. Hassan, for this nice introduction. So my talk is about the worst thing I don't like it in operating diabetic retinal detachment. Having a retinal detachment is, you can have multiple things. You can have the fibrosis and the detachment from the periphery, but whenever you have it on the center, on the pole posterior, this is the worst things you can have, because you should be very meticulous in dissecting this fibrotic tissue. Any hole in the posterior pole can end up with a very poor result. So the idea, I started without the bimanual. Then I admitted that I put the bimanual later on. So I found it difficult a little bit to peel it safely without the other chandelier and the other hand. So I put the chandelier, as you will see after a while, to make it much easier. In those cases, always better to inject anti-VEGF 5 days back, as in Europe. In Japan, they injected 2 to 3 days just before. And to be honest, I don't inject much during my cases because of the waiting list and the difficulty of bringing the patient to the clinic for a logistic reason. Bimanual is very helpful, actually, and I always like to have a different forceps, not the same forceps. So one for crocodile and the other one either maxi grip, so you can alternate between each other and do whatever you want. Whenever you have the plan, or you have the gap between the retina and the fibrotic tissue, this is the first step of success in which you can continue dissecting those material. Then you just continue. Sometimes you slice, you grasp the material slowly, instead of using the scissor to dissect it. So either the scissor in the opening, you can slice the fibrotic tissue, or you can just grasp a small amount and peel it, grasp a small amount and peel it. And this is why I use a different forceps. Whenever it's become a bigger piece, you can eat it by vitrectomy, then re-continue the dissection. Don't ask me about the prognosis for those cases, because I'm sure you are aware with the ischemic retina and all those detachment, we don't expect very good prognosis, but as a surgeon, our target is to have either a flat retina or non-flat retina. We don't care about the functionality much, which is unfair in most of the time. So after dissecting all of it, there is always some remnant of bleeding inside the eye, and as I told you, I don't inject much anti-VEGF. It's not because I believe in, I think it's a luxury, but it's very difficult to bring the patient before the OR to inject it with a shortage of staff. Putting sometimes perfluorocarbon can stop bleeding if you have a lot of bleeding. Sometimes increasing the IUP could help you for stopping the bleeding. And some people propose even high gas IUP for a short time, because clot happen easily in gas and air more than in fluid, because the clot can form in an air fluid, in air condition rather than gas. I think this is my part, and thank you.
Thank you, Dr. Abdullah. Great case, great approach.
I have a question.
Yeah, please, go ahead.
Thank you, Abdullah. Great surgery as usual. I used to do bimanual, and I think bimanual is great, but don't you think in the era of 10,000 cut, beveled, 25 gauge vitrectomy with the improved cutters, I mean, the cutters now are marvelous. You use them as forceps, as scissors, you go in tight spaces, 27 gauge is even better. Have you tried? I mean, I would be interested in hearing what other people think, but I think with the new cutters, I'm not doing bimanual as much as I used to. So I'd like to hear what other people think about this. Or
I
maybe
totally agree with Dr. Saad. I think the small gauge, the advantage of small gauge is to have a small opening in which you can really have a safe approaching to the retina, because small opening will demand a high vacuum just to have the same risk as you have it with 23 or 20. The issue with the 27 is it's fit for the mild to moderate tractional detachment. With this type, I don't think you can remove it with the 27 gauge, but definitely it saves a lot in the mild and moderate bimanual technique. The second thing is whenever you decide to go for a small gauge, like 27, for example, you have to have all the plat of 27. So you have to have the forceps in a case you need it. You have to have the back flush 27 in a case you will do air fluid exchange. And you have to have the injector in a 27 silicone if you are going to inject the silicone. So in a good condition, definitely this will be an luxurious choice.
One other point also about using silicone. I definitely, in diabetics, I definitely prefer gas. And I have no problem with patients rebleeding, by the way, because then if they rebleed on gas, you can always do gas fluid exchange, which you cannot do, unfortunately, with silicone.
But I assure you, there will be no bleeding after 2 weeks of silicone. It will disappear. Any bleeding under the silicone, it will go. Patient will be face down, it will slide away from the macula, and the eye will reabsorb it.
I would just add to what you said. When you do 23 gauge and using 25, you will find difficulties in the beginning. But with the time that you are using 25, it is really one of the really gentle, probes. It's helpful a lot in diabetic, traction retinal detachment. I'm not talking about these types of, thick, membranes, what we call it volcano. Talking about traction retina, very thin retina, having a lot of, epicenters that big. You have a lot of big xeno inside. 25 gauge, it is perfect. It will get in, you use it as a bag, and might be a one hand, and get it in. When I have thick membranes or combined, rheumatogenic retinal detachment with this thick membranes, bimanual chandelier is helpful. The only enemies we find in these cases, usually the bleeding. When you have bleed, it is too difficult then to get in. It might be helpful in sometimes when you are doing these cases with the 23. And hybrid, ones, usually is the best, but it's not provided in Saudi Arabia. It is available in other countries. And you hybrid, you have CAN 25 and 23, and you get in and use it. It's a good case, and usually I'm putting diabetic, TRDs case by case. It's not applying the same rules for every one of them. Dr. Bahrani?
Yes, I just, I was just saying the last point. I mean, every case I deal with it just depending on the type of TRD and bimanual. I still use bimanual, and I use, the 25 gauge. I use 25 gauge for all my cases anyway, so that
As
was
we
the
have,
last point. Yeah.
As we have 30 seconds, now this is your time to ask Dr. Saad the question of endophthalmitis.
I forgot.
You forgot? That's good. I would like to thank you all for your attendance, and I would like to call all the speakers to have one picture here together. For memory for the Saudi Retina Group.
Dr. Yahya. Actually, we missed Dr. Adil, but I don't know. Dr. Mahdi, all the time you are supporting us, right? All the time you are supporting us. This time we're supporting لا هو جوزني الله يجزاكم بالخير. طيب خذوني معاكم يا اخي. يا الله لا والله لا، خذوا بعدين يا اخي